we've turned the camera on live. We're going to start the program in just 30 or 45 seconds as we wait for the system to allow everyone to get into the virtual room so they can hear from our speakers today. All right, it looks like we have a pretty healthy gathering on the of attendees and growing quickly. So just another 10 or 15 seconds, I'll get us kicked off. Good afternoon, everyone. My name is Kent Lassman. I'll be your host for the next hour. This will be the first policy forum of the Competitive Enterprise Institute for 2024, and I'm very happy to bring to you a conversation with two gentlemen who are experts on the law and economics of health policy. Today, we're going to be talking about pharmacy benefit managers, PBMs. It's an issue that has captured the attention across Capitol Hill. And there are a wide range, half a dozen proposals or so, to change the marketplace for how PBMs operate. My aim is to clarify what all the excitement is about, what role PBMs play, and more generally, to help you understand what's at issue. There's lots of rhetoric and bumper sticker slogans that are getting thrown around, and it's important to understand what's behind all of that, how these things operate in the marketplace. I'm going to be joined today by a repeat guest for CEI, Casey Mulligan. He's an economics professor at the University of Chicago. He's also taught at Harvard, Clemson, taken fellowships from the National Science Foundation, I believe, and our senior fellow, Dr. Joel Zinberg. The two of them, this is something of a reunion. Not only do they frequently collaborate, but they were colleagues several years ago and in the administration. They had senior roles together at the Council of Economic Advisors, the chief advisory group for the President of the United States about economics and economic policy. Throughout the next hour, I'm going to encourage you to be part of the conversation. There's two ways to do that. You can use the Q&A function found at the bottom of your screen, or send an email to events@cei.org. And those questions will get filtered into me, and I'll try to get them right into the conversation here. So let me start by saying thank you to both of you. I'm excited for the conversation. Joel, you wrote about this issue in a policy paper for CEI back in September. Casey, you've been doing your own research, developing empirical models to understand PBMs and the value that they create. And I'd like to get started and maybe turn to you first, Joel, and simply ask, what are these organizations? They're private sector companies, these benefit managers. What do they do? What role do they play? And how should we understand this latest hot buzzword, three-letter acronym, PBMs?
Thanks, Kent. So as you say, PBMs are private companies. They developed in the free market to provide pharmacy benefit management services for health plan sponsors. And as the number of prescription drug benefit plans increased, so too did PBMs. So you now have a situation where about 90% or more of Americans have prescription drug benefits. And most of those plans have found value in having PBMs manage that benefit for them. So what the PBMs do is they design the benefit plans, they negotiate prices, they negotiate discounts from the drug manufacturers, they negotiate discounts from the pharmacy who are part of their drug benefit plan. They design those plans, they encourage utilization of drugs in a sort of comprehensive, cost-effective manner. And the outcome of all this is that you end up with real competition in the market, lower prices, and improved health ultimately for the patients who are the health plan subscribers. And I think you can, there are about 70 of these PBMs currently in existence nationwide. And I think it helps to get some sense of what this complex market looks like, because very often the rhetoric makes it sound very simple, and it's not simple at all. But I think to get some sense of this, if we could put up a chart that was in the paper that you referred to, Kent, that I think would help people see where PBMs sit in this system. So if you see right in the center there are the PBM, the pharmacy benefit manager, and on the left you have health plans, and they have clients, they have patients who sign on, and these healthcare plans can be private, they can be governmental, things like Medicare, Medicaid, and those folks sign on in the healthcare plan on the left. The healthcare plan negotiates with the pharmacy benefit manager to design a health benefits program for them. And the pharmacy benefit manager in turn negotiates with that drug manufacturer on top. And he also negotiates with those pharmacies in the lower corner. So with the drug manufacturer on top, negotiating about the price. They'll negotiate a price and the terms that they'll buy it on. And then with they'll negotiate which drugs can be included in the plan. That's called the formulary. They also negotiate in terms of the formulary, where those drugs sit within the formulary. It's what's called tiering. So depending on what tier it is, it determines the co-payment or the out-of-pocket expense that one of the patients will have. So obviously something that's got a lower out-of-pocket expense is more attractive to a patient. And it's more attractive to a drug manufacturer because that means they'll sell more. So ultimately their goal is to extract lower prices based on formulary placement in general and formula placement in particular, the tiering. Then in terms of where they stand with the pharmacy, they're negotiating, can the pharmacy participate in their network? Does the pharmacy have to give them any kind of particular discounts? What does the pharmacy have to do to comply with the health plans that pharmacy benefit managers try to promote? And here I'm talking about things like many of the pharmacy benefit managers have gone into trying to assure patient compliance with the drugs. They want to check in on the patients, make sure they're taking the drugs. They want to check in on the physicians to make sure they've been writing renewals. They want to make sure, as sort of an overriding principle, is they're trying to provide appropriate care to patients at the lowest price possible. So that's kind of the general outline of the thing. And it's worth noting that many of these rebates and discounts and payments back occur after the point of sale. So it's after the patient has actually gone to the pharmacy and picked up the drug. And it's also worth noting that the PBM actually never handles the drug. All the PBM does is create this network that facilitates low prices and good compliance with healthcare demands.
So it seems there's two essential features that I think I see in your chart and through the discussion here, and I want to test my idea and make sure that I'm on the right track with trying to understand the role that they play. And this might help you explain where the value gets created in this market. One is we're talking about insured people who have insurance and are receiving their medications, their drugs, through their insurance plans. And that's, as you said at the top, about 90% of the market. So this has nothing to do with over-the-counter. If I were to go pay at the drugstore for something that I had a prescription for without insurance, I could just pay over-the-counter for something. Mm-hmm. And then secondly, the way the chart is designed instructively, the PBMs are in the middle. So Econ 101 suggests to me that perhaps there would be deals not made if there was not someone, as you said, facilitating or organizing. Could you talk a little bit about that latter point and how, where is the value in this? Because it's complicated, and certainly somebody is creating something, otherwise they wouldn't exist.
Right. So as you point out, it's in the middle, and PBMs are often derided as just middlemen, as if there's something obscene about that. But the fact is, middlemen are ubiquitous in our economy. All industries have middlemen, and they're brokers, they're facilitators, you name it. There are a variety of terms applied, but they're used by multiple industries for all kinds of products. There's nothing unique in this setting about that. And the way they create value here and in other industries is by negotiation, and it's through creating competition. And in the case of PBMs in particular, they are functioning very much as a group purchasing agent. So they will negotiate with the manufacturers and pharmacies. They'll negotiate the various markups and dispensing fees with the pharmacies. They negotiate the rebates that they'll get back from the manufacturers on the other hand. And they're acting in a way that, to put it in sort of more common parlance, they're acting like Costco. They're pooling the buying power of multiple people and creating a situation where they have more negotiating power than any individual does. And as a result, they can demand better prices and better terms. And that's reflected back to the patients in terms of lower premiums on their insurance. And they do this basically through sort of what I alluded to before, what's called selective contracting. They can say to a drug manufacturer, let's say for argument's sake, there are 5 drugs in the therapeutic category. They can say, look, we're going to select a few of these drugs, not necessarily all of them. You can be on board and sell a lot of your drug to our clients, or not. So that's a stronger position for the various health plan sponsors to be in. And then they can, compound that by saying, and we'll put you in a better tier, so you'll sell even more of the drug. So that creates a situation where you get lower pricing. And of course, on the other hand, they do the same thing with pharmacies. They say you can be in our network or not. And if you're in our network, that's going to drive customers towards you. If you're not, then of course you're going to suffer. And the same thing in terms of getting discounts and things like that from those pharmacies. So it's lowering costs through competition. And arguably, I think it's improving health too, because what PBMs have proven very adept at doing is encouraging the use of generics. That lowers costs, number one, and it makes the drugs much more accessible to people. 9 out of 10 prescriptions filled in this country now are generics. They also have these clinical and disease management programs, where I mentioned before, they encourage the correct usage of drugs. They make sure that people are adherent to their physician's orders in terms of taking the drugs and doing it on time. And by obtaining lower prices, they're facilitating access to some of these expensive new drugs, the branded drugs that may have just come out. They may be the sole drug in a particular therapeutic category, but by getting a better price for it, they're enabling more people to use these drugs, many of which are quite beneficial. And as a result, they get the benefit of the drugs, and they in turn lower their need to utilize other healthcare services, and with the attendant risks that those healthcare services might have, and the attendant expenditures that those healthcare services might have. So that's how they do that.
Yeah, we have dozens of these companies out there, 70 plus you cited, and I heard, I think, 3 principal benefits. And Casey, I want to turn to you to ask about how big are these benefits, or how do we understand the value? But one is the prices. Overall, the prices come down. 2 is the drug utilization, which is doing a better job of prescribing and or people using the right dosage, the right drug, the right combination. And then the 3rd is access to newer, novel, oftentimes high impact pharmaceuticals that otherwise would be out of reach because of their newness, their price associated with all the research, the tremendous amount of investment that went into creating them. Those three different categories, Casey, did you combine them all and get a look at when Joel uses a phrase like eventually this moves toward better health? How much health? How do we measure that? How do we know the value that's been created by PBMs, or what's at stake when we have this congressional debate?
Much of the value relates to utilization. And I want to kind of give my perspective, not disagreeing with Joel, but laying out the points a little differently that allows me to make an estimate of the value of these things. So, as Joel said, the PBMs have emerged in the market. Joel had those various arrows coming out of the middle circle and into the middle circle. Those are optional. The arrows could go direct from the plan to the manufacturer, from the plan to the pharmacy. Manufacturer could say, hey, PBMs, I don't like you. I'm not dealing with you. I'm going to deal with the plans directly. That would break no law. There's no problem with that. But people don't want to do that. PBMs have come and said, we would like to be part of your transaction, and we have something to offer. And all participants have said, yeah, we want you part of the team, even though you're going to have, earn a fee or whatever. We want you part of the team because you make us better. I mean, that even you guys mentioned, well, the uninsured aren't part of this. That's actually not true. It's an innovative market, and there are companies who have entered in there to stand between the uninsured and particularly the pharmacies. GoodRx is a company that does exactly that. So these are voluntary. That's the first thing to remember. The second thing is that these discounts are the result of a negotiation. They're tied to achieving the utilization targets. That's why the manufacturer goes along with it. The manufacturer by itself, they don't want to give discounts. And we'll get to this later. That's why they're approaching government regulators, because they would like to not have the discounts, but they do like the other side of the contract. The PBMs and plans have an obligation here to make the drug accessible to their members. And so that's a two-sided thing. And these rebates, we should also remember, are rare for generics. So while Joel mentioned the PBMs deal with generics, the actual flow of funds back to the plans don't occur for generics. And one very interesting thing that's been studied a lot in economics is, well, what happens on the transition from brand to a generic? Basically, what I'm talking about is when the patent expires. What happens there? Well, the list price falls a lot. That part's kind of famous. Generics, when they're healthy, at least healthy and economically, they're a lot cheaper. But what's been found time and time again is the utilization does not increase during that transition to generics. And especially when those are covered by insurance. So that's a very strong piece of evidence that even when they're in the branded phase, the insurance companies are doing a great job of getting the treatments to patients who need it. And that's really that amount of the utilization effect. How much utilization would be lower if we didn't have these contracts during the branded phase. That's the source of a lot of the benefits that I estimate. And utilization kind of has three effects. One is directly, you might say, that the patients, they're happy to use a new product that does better for them in side effects or outcomes. And so that's one category. The other category, I believe Joel mentioned this, is that utilization of prescriptions helps lower hospital costs and physician costs, because if the diabetes doesn't get out of control, then we don't have much more expensive treatments that need to be used. And that connection between prescriptions and hospital costs has been investigated, and I use those quantitative estimates. And the third is saving the government money. The government is a major payer for health insurance. And if insurance gets more expensive because the manufacturers aren't giving the discounts or the pharmacies aren't giving the discounts, then the government has to pay more. Now, government's largely involved in transfers, and none of my analysis do I count transfers. You know, everything's a net that I calculate. So we get a benefit only if the winners gain more than the losers lose. But with the government, as we know, when the government has to raise money, they distort the economy. So I account for that too. And those kind of three areas each add up to about 50 billion a year benefit each. And then so combined together, that's about 150 billion a year benefit from having PBMs there in the middle rather than having the arrows go direct.
And Joel, this point about Medicare is something you touched on in your study. PBMs helping keep Medicare costs in check. The government as an actor itself, because it's such an important player in the provision and payment of health services and in health insurance, excuse me. Has the government jumped into the debate here? Or has this really been an activity of big companies and big industries lobbying? Or do we see CBO or the Office of Management and Budget or the centers that manage Medicare? Are they doing their own estimates about how these changes to the law, proposed changes to the law, might affect their long-term expenditures?
Well, as you alluded, the government's involved on the Medicaid front and on the Medicare front, and we're almost at about 20 years now of the Medicare Part D program, which pays for, it's a voluntary program to which I think about 5 out of 6 Medicare enrollees have decided to enroll in the Medicare Part D program as well. But the reality is the government pays for about 3/4 of the cost of Medicare Part D. So it's a real expenditure by the government, as Casey mentioned. And you know, up until recently, you've had many government agencies, for example, Federal Trade Commission. They recognized in a series of letters where they were asked to comment about the selective contracting that PBMs do, that they thought this was pro-competitive, and they credited it with keeping drug prices down. You've even had, you know, groups that are sort of on the other side of the ideological spectrum, I would say, from a CEI, come out and admit that this indeed has been what's happened. So I think you've now had a switch, and there's a different focus and a different approach to drug pricing than we've had in the past. And you've had attempts now by Medicare through the Inflation Reduction Act, so-called Inflation Reduction Act, to start negotiating drug prices. You've had calls for what are called march-in rights, where the government will essentially march in and steal intellectual property and license it to other people to presumably produce and sell drugs at lower prices. You have all sorts of calls now for intervention in the market, when in fact the market is actually functioning quite well. And as I think Casey pointed out, this is a very fluid market. There are a lot of smaller players coming in who are upsetting the model that I outlined in that chart. They're willing to sell directly. They're willing to, instead of relying on rebates, they're willing to do cost plus type things with an administrative fee. And you even have some of the major PBM players suggest that they're going to move to that model. And it goes on both ways, by the way. California's Medicaid program announced that it was going to stop dealing with, I believe it was CVS, and look into things like the Mark Cuban program, where they just apply a fee, a set fee, to each of the prescriptions. And now CVS has sort of backtracked a little, and they may indicated they may start offering that sort of plan. So it's a very fluid market. It's the market that allows for free competition, market entry, and because of that, you have all sorts of new plans that are really probably going to be short-circuited by these proposals that are now pending in Congress.
Yeah, I want to add, Joel mentioned about the government negotiating, and that makes it sound kind of similar. What's the difference if the government negotiates versus a private corporation negotiates? Maybe the government's more accountable because we vote, blah blah blah. Well, this is a very different negotiation. In fact, you might think, well, PBMs, they get lower prices from the manufacturers. That hurts drug innovations because manufacturers don't have as much money to fund their drug research. Not true. What the PBMs do, and this is one of the reasons why the manufacturers want that arrow going through the PBM, is when they have a new product, and it's not even been approved yet by FDA, they're talking to the PBMs and they're saying, you know what, can you line up the financing? Can you line up the physicians? Can you line up the health plans? So when our drug is available, your patients who need it can get it immediately. And so the drug manufacturers actually, they lose money on the whole from PBMs, but they earn a lot of money with their unique drugs in those first years. And those are the ones that count for the R&D calculus. Of course, the government are going to be totally the opposite. The government's going to be very slow to adopt. You're going to have to appeal to committees and blah, blah, blah. You just look at the Europeans who have the government do this negotiation. They get the drugs, 3 years later than we do. So I'm a little worried that the English language has these homonyms, the government negotiation and PBM negotiation. They sound the same. They're very different.
Yeah, no, I use the term negotiation. I mean, it's frankly a euphemism because it's anything but a negotiation. It's a situation where the government selects, they're initially going to select 10 drugs, and then they'll add more drugs in subsequent years to quote unquote negotiate on, and then they'll set the price. And there's basically no administrative or judicial avenue to appeal either the selection or the negotiated price. So it's really price setting. It's not negotiation in any normal usage of the English language. But that's the way the IRA phrased it, as negotiation.
Yeah, I'm thinking now of the relationship I have when I negotiate with the state of Virginia about my taxes, and when I negotiate with the local car dealer about a new car price. It's a different situation. Entirely. I want to back us up a little bit, because this is really important to get our arms around. We have a lot of congressional staff watching today, and I assume there'll be even more once we put it on YouTube on our website. But you've each touched on the role played by rebates, and I'd like Casey, if you could pick up on this. Rebates come in for a lot of hostile commentary. What do they do? How do they operate? And is this alike or different than most markets that we would understand that there's a market maker? There's someone in between two big players. What's the importance of rebates? Oh dear, what do we have here?
I have my subliminal advertising here. Rebates are contracts. I mean, that goes back to what I said in the beginning, that these arrows are going both ways. The manufacturers are voluntarily giving these rebates in a competitive setting. Now, if they can get the government to stop the darn competition, then they would love that. But in a voluntary competitive setting, there's a two-way street here, and health plans have to do something in order to get the rebates. The rebates will not be given unless the health plans do something. And the plans won't do their part unless they are getting something, a rebate. So maybe a better way to think about rebate is a volume discount. It's encouraging utilizing the product. And we have rebates or volume discounts throughout the economy. Joel
So-
mentioned there are middlemen throughout the economy. We have volume discounts throughout the economy. Take the restaurant that's across the street from my house. They got only Pepsi, no Coke, Pepsi, right? And why do they do that? Do they do that to make people like me who like Coke angry? No, they do that because Pepsi gives them a very cheap price when they are willing to put Pepsi in that favored position. In fact, it's the only position in the restaurant. Now, the PBMs often don't go that far to say we're going to only have only one, but that is the idea. To give all or nothing for our customers means that our customers get a great price.
So if people hear the term rebate and they think there's a special secret side deal, some sort of cronyist setup, really what they need to be imagining is volume discount. And
Yes,
it's a terminology point that is important here for how the market operates.
And the customer gets that. I mean, the customer, a drug, once a drug is under the rebate contract, it's much cheaper at the counter than it would be if it weren't under the rebate contract. Now, some of the rebate goes to the plans themselves that make lower premiums as well. But even at the counter, when you're part of the health plan and they've negotiated with the manufacturers, you're not paying that list price at the counter, not anywhere close. You're paying maybe a quarter of that. And a big reason why you've gotten that 75% discount as a patient at the counter is the rebate contract that was there, that your plan got for you with the help of the PBMs.
Yeah, and I think it's worth pointing out that even though the rebates, which are one of the targets of much of this legislation, are described as something nefarious, almost all the rebate goes back to the health plan sponsor and through the health plan sponsor back to their patient enrollees in terms of lower premiums. So it's over 90%. In fact, one study of Medicaid Part D said that 99% went back to the plans. So it's always painted as if there's some horrible action and a rebate is a dirty word, but in fact this is just a way of negotiating among many. They're negotiating on a whole host of terms, but rebates are one of those terms. And the good news is it ends up in most of that money going back to the plan sponsors and through them back to their patient enrollees.
And we know that step by step, that flow back to the enrollees, because it's a competitive market, right? This is not a government provision where there's one provider where those rents, those economic gains could be captured.
Right. I mean, that percentage of going back to the plan sponsors has been rising steadily over the years. It wasn't always at that 90%, but as you had more and more competition, it rose. And it's also worth interestingly noting that the rebates themselves are actually, studies have shown they're higher in the government programs. They're higher in Medicaid and higher in Medicare than they are in the private plans. So, they're actually benefiting the taxpayer the most in those government programs, more so than even they do in the private programs.
It's also not just the money.
Okay.
There is money flowing back, but there's also services. And, we take for granted, we go to the pharmacy, you show your card, you're done. Compare that when you go to Dr. Joel's office. There's all kind of flow of paperwork that keeps trickling in for weeks, if not months. There's an amazing computer system that the PBMs have built for the consumer, and they don't see that. And Joel mentioned, managing utilization and checking for drug interactions. I mean, that takes technology, that takes expertise, and those people need to work for a living as well. But because it's a competitive market, plans are deciding, do I want, a PBM that gives more of those services and less of the cash, or more of the cash and less of the services? That's all worked out, and it's a matter of choice, and the plans have a menu there.
So this, as I asked the question about rebates, it started to hint toward one of the first questions I have from our audience, from Frank, and he's pointing toward vertical integration when he asks, there would be little controversy if the PBM function was just part of the health insurance company. What's the market dynamic that makes this a separate company?
Well, they began, you know, way back in the day, let's say in the 60s, the 50s, they didn't manage benefits, and it got to be expensive. And there weren't as many pills back then that could help us, but it wasn't managed. And then plans started to manage the benefit and realized, we can do better for the patient, we can do better for the bottom line if we manage this. And then some of the plans are saying, once we figured out this management thing, maybe we should share it with other plans. And it works on a scale bigger than the plan itself. And so that's when PBMs became a standalone entity. And again, it's common in markets. And one of the examples I use is OpenTable, right? To go to a restaurant. Each restaurant does have its own app to book a reservation, right? OpenTable can do it on a scale, and OpenTable is not the only one. And so that's how PBMs got to be their own company. And there's back and forth. Sometimes PBMs have gone back into health plans. Sometimes health plans have stopped using external PBMs and use their own benefit managers inside. This is also a fluid situation. One thing I worry about is the government regulations will distort that. In particular, a lot of these regulations target the standalone PBMs who are not integrated, say, with a pharmacy, a retail pharmacy, or not integrated with the health plan. And that's going to push, it's an old result from Oliver Williamson, the Nobel Prize-winning economist, that when you start to regulate business-to-business transactions, what you're going to start to see is a lot of vertical integration, and a lot of the middlemen will disappear and go in-house.
Yeah, the interesting thing is that I think, what Casey is really pointing out is that all of these plan sponsors have found value in pharmacy benefit management services. And for most of them, they have figured out that it's far more efficient and cost-effective to farm it out to a PBM, let them do it for them. There are some that do it in-house, but they have farmed it out to PBMs. Now, over time, as your questioner pointed out, there's been vertical integration. The three largest PBMs now actually vertically integrated between being health insurers, having their own pharmacy, and functioning as a PBM. But that PBM works for them, and it's also providing services to completely independent companies and independent pharmacies. So it's not an exclusive arrangement where it's vertically integrated and only working for that particular sponsor or those particular pharmacies.
So I think I've heard at least two dimensions here that are important to point out particularly for lawmakers to understand the market. One is that firm design. Not all of these firms look alike. Some are integrated, some are not. Some are large, some are not. And then secondly, there's a dynamism within the market in that PBMs are testing out different ways to make these contracts. And Casey, you were talking about some are relying on the tested, time-tested volume discounts, the rebates. Others are trying a cost-plus approach or other methods to get into the market or to see if they can squeeze out more value, create more value there. This leads right into somebody was listening closely out there. Looks like Ellen was. She wants to talk about concentration. So within discussions of how to regulate or not regulate markets, oftentimes on Capitol Hill, we hear about the size of firms, the number of firms, how concentrated the market is. Before we talk about the PBM market, could you first, maybe Casey, could you tell us what is concentration all about? Some folks are going to be less familiar with the economics of industrial organization than others. So what is it? And then if either of you could address, how does it come into play here?
Well, the issue would be, in a market, how many sellers do you have? That's the simplest way to put it. And a concentrated market would have fewer sellers than an unconcentrated market. A monopoly market would have only one seller. Now, what makes it interesting here is there's multiple markets involved here because the drug doesn't go immediately from the assembly line into the patient. there's different steps. So there's a manufacturing market, and that has concentration built in from our patent system. You're entitled to a monopoly on, at least on a molecule, not necessarily a therapy. There's the market at the retail level, to have a storefront, to have a pharmacist who can talk to the patient. That's a different market, and that can be concentrated or not. There are some fairly big pharmacy companies that we've even mentioned some today, like CVS. And then there's the PBM market, which, as Joel said, they don't have a retail front. They don't make pills. They don't even touch the pills, but they do the kind of business side. And so concentration could be an issue there. And in principle, you could imagine, a monopoly PBM. That's not what we have. We have many of them. Some are bigger than others. And a lot of times I've been to hearings, they will start out talking about, well, we have 3 really big PBMs and the rest aren't so big. And then they go on to talk about legislation that will only encourage the big PBMs at the expense of the little ones, but whatever. There's almost no analysis of all these regulations of what their competitive effects are. The view is that, well, we have concentrated PBMs, so if we punish PBMs, that will magically make it less concentrated, when it does the opposite. You punish a business, you're not encouraging people to join that business.
Yeah.
Is it the case that the essence concentration is interesting, but what really matters, as you said, for competitive effects, we care about the ability for market entry and exit. Is that what we're looking for here?
Yeah, I mean, there's the old question raised by Baumol, if you just have 1 or 2 producers, is it competitive or not? Well, it depends on whether they feel threatened by entry. Which really neat about this market that we've already alluded to is, unlike, say, automobiles, if I'm not happy with Ford and GM, it's not like I go in my garage and build my own car, right? But a lot of these plans can build their own PBM. They did it before, they could do it again. And probably as we're speaking, there's probably some plan who is doing exactly that. So you have the PBMs that are actually out there and being active, but you have tons of plans who are a very real threat to get into the PBM business themselves.
And Joel, I didn't mean to step on you. You had something to add there.
No, I was going to just to put a little, add a little color to what Casey said. If one looks at the drug wholesaler market, the top 3 drug wholesalers are about 80% of that market. If you look at the large pharmacies, the top 3 account for 50% of pharmacy sales in this country. So it's not as if PBMs are some unique category. There is, as Casey said, there are 3 very large ones. They're in the 70-something% of the market, but then you have another 3, so that take you up to a little over 90% of the market. So meaning 6 companies, which is not, especially in terms of American industry, an indication of compensation. And it's worth pointing out that it's always coupled with this notion that PBMs are somehow price gougers and they're getting unfair profits. But when you look at the drug distribution system as a whole, PBM's net margins are actually smaller than most of the other players. One estimate put them at 2% net margins, which was smaller than the drug manufacturers, who were about 25%. It was smaller than the pharmacies, which were about 4%. The only one it was larger than were the drug wholesalers. So they're actually doing worse than most of the other players in the drug distribution system.
It puts them in the notoriously low range of grocery stores, operating at 1 to 2% net. Let's see if we can turn our attention. This has been a very helpful overview of what these companies do and why the market exists. But we have legislation on the table, and there's, like I said earlier, 5 or 6 different pieces. They've moved at different rates in the House and Senate. Some have received votes. Some are in committee. Casey, you looked at specific legislation. Is this right? And can you tell us about what overall are there themes or commonalities among the proposals?
Yeah, there is a theme. All the proposals have this feeling or sentiment of punishing PBMs. So that would be one common theme. Of course, I raised the question why you want to punish them, but putting that aside, that's kind of be a theme. The other common theme among these regulations is who supports them. There are two parties that support them: the drug manufacturers and the retail pharmacy companies. It's not the health plans. The health plans aren't saying we hire these PBM people and government, we need you to help us in dealing with them. They're not saying that at all. It's the manufacturers and the pharmacies. And that shows up in my estimates that I said I calculated a net benefit, but a net involves, taking out the losses of some of the parties. Who's the losers from this PBM operation? It's the manufacturers, because PBMs magnify the competition among manufacturers, and like any seller, they'd rather compete less rather than more. And then they magnify competition among the handful of big pharmacy companies that Joel mentioned. And they're not winning this battle in the marketplace, so they're going to the government for protection.
Yeah,
and that's really a difference between, PBMs, we say, well, they're not unusual in terms of competition. What they're unusual is that their job is to enhance competition. And that's different than manufacturer's job is to manufacture, right? Well, the PBM is manufacturing competition in these other markets, in the retail market and in the manufacturing market. So they have natural enemies, and those enemies have shown themselves.
Yeah, Ken, I think it's worth saying, when you mentioned there were a few different, really a slew of different proposals percolating through Congress, and one of them, I believe, has been approved by the entire House. But there are two common features to all of these programs. One is limit or eliminate the rebates and other types of discounts that you have in the current system. And the second is a demand for quote unquote transparency and the revelation of all kind of pricing and confidential contract terms that are now kept, they're now confidential and proprietary, making those public. I've sort of two observations about that. One is what's the problem they're trying to solve? This is legislation that's solving a problem that doesn't seem to exist. When there are surveys of businesses that talk about the insurance plans being actually quite satisfied with the current system with PBMs. There have been, as I mentioned earlier, several organizations saying that the PBMs and the current system have been responsible for keeping prices low and keeping the increase in drug prices under control. You're having lower premiums. As a result, you're having lower taxes to cover those premiums in the government programs. You have a situation, as we alluded to before, where there are no barriers, or not particularly high barriers to enter the market, so you have competition. So there's no problem that, and as I said, there doesn't seem to be excess profits by the companies either. So what problem are they solving? And they're proposing something that stands a very real risk of making things worse, of decreasing competition, of increasing prices, of ending this market evolution that we alluded to earlier, where you're having smaller companies and new entrants come in and propose different ways of approaching matters. If you start doing the types of things they're talking about doing, banning rebates, demanding transparency, you stand a very real chance of limiting the types of things that people can negotiate on. And you're most likely going to hurt the small companies who utilize their ability to offer transparency versus rebates. Let's say they can't demand as high a rebate as a big company, but they can say, well, in return, we'll give you the kind of transparency that you were looking for. That's one of the things they negotiate on. If everyone now has to be transparent, then they've lost the ability. Or if you create a situation where everyone's rebates are exposed, so everyone knows the prices, you're helping the bigger companies. You're not helping the smaller companies. So this is really, these are counterproductive proposals that are not solving any problem.
Now Casey described it as, I don't think I'm being unfair to summarize it as, this has to do with legislators coming in with ideas to reallocate value that's on the table in a market. You have all these different players. They do different things. Some manufacture, some have a storefront, and there's value created, economic value that translates to health, better health outcomes. And the proposals would reallocate who gets more and who gets less. But that seems to be a separate thing from this transparency point. And I just want to see if, before I turn to you for closing arguments, see if we can explore transparency for a moment, because I'll tell you, my instinct on the first point about reallocation is that's actually not what happens when Congress blunders into a healthy market. Typically what happens is they destroy value, right? There's value on the table, and then it suddenly becomes smaller. But it gets to, Joel, you're talking about the relationship for these companies to be able to bargain and negotiate and contract with each other. If you take away one of the provisions, one of the things that they might choose to bargain on, transparency, that it becomes less healthy, less competitive. We see less dynamism. Oftentimes, I think transparency comes with a halo around it. And I like to remind people that transparency is very good for government. We want to know what our public actors are doing. We want to make sure they're not corrupt, that they're not self-dealing, those sorts of things. But transparency in a market and transparency in pricing, Casey, you might be the only guest I've had in the last many years who's written a textbook on prices. Could you talk about the role of transparency and how it operates here?
Yeah, now we could call it transparency. I call it required disclosure.
Okay.
That private entities need to show their private business. You and I have a deal. It's not between you and I anymore. We need to show it to the world. Why would the government want that? Well, the sense you get if you go to these hearings is the number one reason is the government wants to manage the business, and so they need to see inside. So this is really disclosure to the government so that their next round of regulation can further micromanage what they're doing. I think that's the real thing that's going on. Now, the other concern is that, this is the PBMs, they don't invent pills. They don't decide where to open a store, what street to open it on, what floor to have it on. They are creating business models. And so you're giving away their secret sauce. It's like telling Coke, you need to tell the whole world what's the recipe for making Coca-Cola. And in that you're taking away that proprietary information. That's going to undermine, innovation and productivity in this industry, which is, as I said before, is very much what the pharmacy companies and the manufacturers want. They don't like that PBMs have figured out so many ways to force them to compete with each other.
I think I have indulged myself for almost an hour here, but I want to make sure that we turn to each of you for the high points and get your closing thoughts. Remember that you're speaking here not just to our audience this afternoon, but there are legislative staffers and members who are going to listen to this program over the coming months and help inform their approach to this policy question. Joel, maybe if I could turn to you first, and then Casey, what are the most important things that you want people to know, either coming from your research on this topic that you've each published, or as you've watched the debate unfold in the past year?
Well, I would remind people that this is a voluntary system. This is a system that has grown out of the market. The various actors in the drug distribution system saw there was a way to improve the market, and it involves pharmacy benefit management services. And when they realized they couldn't do it themselves, they could rely on these companies, PBMs, that function as middlemen, as in many other industries, and do it in a more efficient, cost-effective manner than they can do it themselves. And the fact is, every one of these companies, whether it's the drug manufacturers, the wholesalers, the pharmacies themselves, they have an option. They do not have to deal, as Casey said, they don't have to have those arrows. They could do it separately, and sometimes they do try to do those arrangements. Sometimes they're successful, sometimes they're not. But they voluntarily deal with the PBMs, not because the PBMs are particularly nice guys, but the PBMs do a good job at making the system run. And in doing that, they add value for the consumers, they add value for the taxpayers. And we should think long and hard before we go in and solve a problem that doesn't exist and run the real risk of screwing it up by decreasing competition, by decreasing market innovation, which will result in higher prices, just what you didn't want, higher prices, increased costs to both those private plan enrollees and to the taxpayer who fund the government health insurance plans.
Casey, walking away, what ideas you want to make sure our audience hears?
I think going forward, we need to look at all these proposals from a competition perspective. What would the law or the bill, what would it do to the number of pharmacists, to the number of manufacturers, to the number of therapies that we have? You know, you can have in the preamble the words competition or concentration, but that doesn't mean the actual statute serves that purpose rather than serving the opposite. So I think you want to look at it from a competition perspective. I think you want to ask, you know, who are the supporters of this bill? If the pharmacy companies are supporting the bill, then how is it possible that it's encouraging competition among pharmacies? How could patients be getting a better deal? You know, a transparent monopoly is still a monopoly. So the problem is the number of sellers, the ease of entry, like Kent said earlier. That's all how we do competition analysis. We don't, maybe there's a need for a new economics, but for the economics we've had for 100 years, we don't analyze the transparency as a way of figuring out why firms charge too much. We analyze the entry. We analyze the cost of doing business. We analyze the number of sellers that are out there. And I think that should stay the focus.
I want to thank you both. This is a treat for me because I get to concentrate a dose of learning a lot in a very short amount of time. I know there might be follow-up questions, and I encourage people to contact either of our speakers today. Both of them are, you can find their information online through either CEI or the University of Chicago, which I see just over Casey's shoulder, America's second city, a wonderful place to be. I want to remind our audience that in just a moment, we will close the program and automatically a short 45-second survey will pop up. We take those survey results very seriously. I read each of the answers, as well as the whole team here, the events team, to bring you better programming throughout the year. Speaking of which, this year is a very special year for CEI. It's our 40th anniversary. We're looking forward to a blockbuster events program, bringing more policy forums like this to you, including a visit to Edinburgh, Scotland in May for our annual policy summit, and the Julian Simon dinner, which will be in September. I look forward to seeing everyone there. And thank you again to both of our speakers, Dr. Joel Zinberg, Senior Fellow here at CEI, and Casey Mulligan of the University of Chicago.